Hi everyone, and welcome to our module on Mycobacteria. Mycobacteria are bacteria that contain a unique substance in their cell wall called mycolic acids, and that's how they get the name Mycobacteria. And mycolic acids contain lipids, so these have very lipid-rich cell walls, and they're described as acid-fast bacteria. So what does that mean? Acid-fast means the bacteria is resistant to decolorization by acid after staining with a substance called carbofuction. In general, they don't gram stain very well. They're technically called gram-positive in some books because they weakly take up the gram stain. But in general, we describe mycobacteria as acid-fast bacteria. The stain we use to detect mycobacteria is called the Zeal-Nielsen stain, or the acid-fast stain, and this stain contains that substance carbofuction. It's used to detect all mycobacteria, especially tuberculosis, and you should know this for step 1. If you hear of the Zeal-Nielsen stain, they are probably talking about tuberculosis. It's also used to stain for nocardia, and this is an example of some acid-fast bacteria. Initially, all the bacteria will take up the carbofuction and turn purple, but then the acid decolorizer will wash it away from all the bacteria except the ones that are acid-fast, like these on the screen. The most important mycobacteria far and away is tuberculosis, and I talk about this in its own module in the pulmonary section. But we'll talk about the other three you should know for step 1 in this module, and that includes Mycobacterium avium, Mycobacterium concise, and Mycobacterium leprae, which causes leprosy. So Mycobacterium avium complex is a couple of different bacteria. They're often just called MAC, and they are the most common non-tuberculosis mycobacterial infection. The reason it's called a complex is because these infections often include more than one bacteria. Mycobacterium avium and Mycobacterium intracellular both are usually involved, and these are very slow-growing acid-fast organisms that cause infection. MAC is found in the water and soil. It can be inhaled or ingested, and if you don't have HIV/AIDS, it's a very rare cause of pulmonary disease. But what you need to know, especially for step 1, is that this can cause a severe disseminated disease in people who have end-stage HIV. So in order to get a disseminated MAC infection, you have to have a very low CD4 count. It has to be less than 50. Most of the symptoms are going to be nonspecific, so it's the very low CD4 count that's going to tip you off that it may be a MAC patient being described. A lot of the symptoms are things like fevers and sweats and abdominal pain and diarrhea or weight loss. These don't really help you figure out it's a MAC infection. There can be severe anemia from bone marrow involvement, there can be big livers and spleens, and there can be high alk phos and LDH. One thing that's often helpful is there's usually no lung findings in disseminated MAC, so patients who have a lot of lung abnormalities probably have a disseminated TB infection and not a disseminated MAC infection. But remember for step 1 that the CD4 count is going to be very low in any patient that they're describing who has a MAC infection. The diagnosis of MAC is by blood culture, but remember it's a very slow-growing organism, so it can take 7 days or more to culture, and often treatment is started empirically before culture results are available. The treatment for a disseminated MAC infection is the antibiotic clarithromycin plus ethambutol, which is a tuberculosis drug. But the more important thing to do is prevent a MAC infection, and the prophylaxis is azithromycin. This drug is given to HIV patients when their CD4 count falls below 50, and the reason you add this on to their regimen when their CD4 count gets low is to prevent Mycobacterium avium infections. Next mycobacterium we'll discuss is Mycobacterium concise. This is the most frequent non-TB mycobacteria after MAC. It's got some source in the environment that's not clear. People aren't exactly sure what its reservoir is. And the most important thing to remember about this is that it causes similar pathology to tuberculosis, but it's less virulent. So people will have fever and sweats and cough and dyspnea, and they'll have chest x-ray infiltrates. All these things are very similar to TB, but it's just generally less severe, and the treatment is very similar to TB. And that's about all you need to know about this bacteria. It's a very uncommon and rare cause of infection. And then the final mycobacteria we'll discuss is Mycobacteria leprae, which causes leprosy, which is also called Hansen's disease. And any of you who know stories in the Bible know that Jesus famously cured the leper, and that's because people who had leprosy had diffuse skin lesions, and in ancient times they were not allowed inside of cities for fear that they would make other people sick. So leprosy is an obligate intracellular organism. It grows very, very slowly, and in fact it cannot be cultured, and you should remember this. If you see a board question of a patient with leprosy and they ask you how to diagnose it, don't choose blood cultures or skin cultures. It grows best at very cool temperatures, a little bit below normal body temperature, and this is why infection often involves the skin and the extremities and the face, because those places are furthest away from the organs and lots of heat, and therefore they tend to be cooler. The reservoir in the environment is armadillos, and the mode of transmission to humans is unclear. It causes granulomatous inflammation, which is easy to remember because it's a mycobacteria, and you know that tuberculosis causes granulomatous inflammation. And it's mostly found in developing countries. Most U.S. cases occur in immigrants. So when you think of Mycobacterium leprae, always think of the skin and the superficial nerves, because the symptoms of this disease always include skin lesions and a loss of sensation. That's because it likes to infect the skin and those cool nerves that are just underneath the skin. Now, step 1 of the boards likes to test you on mechanisms of disease, especially immunology mechanisms of disease. And you should know that there is a spectrum of symptoms of leprosy, and it depends on the strength of the cell-mediated response. So tuberculoid leprosy is a very mild form of the infection, and this occurs when the cell-mediated immune system is able to contain the infection. Lepromatous leprosy is a very severe form of infection, and this happens when the cell-mediated response is relatively weak. So let's talk about the milder form of infection first. That's called tuberculoid leprosy. Patients with tuberculoid leprosy have patches of skin that are hypopigmented, and they've lost sensation over the affected area. So they've got an infection of the skin and the superficial nerves, just like we expect for tuberculosis, but it's relatively mild. It's just going to be a few areas on their body, maybe on the head. What happens in tuberculoid leprosy is the body initiates a strong cell-mediated Th1 response, and this contains the infection. You can do a skin biopsy and you'll see granulomas, but you'll see relatively few bacteria because they're being held in check by the strong cell-mediated Th1 response. Contrast that with lepromatous leprosy. So these patients have diffuse skin lesions. This is the classic type of leprosy patient like I've shown up here in this picture. This is the type of patient described in the Bible who used to be shunned in ancient times for their skin lesions. They often have deformed, thickened skin. They will have hypopigmentation and hair loss, and they will have a severe neuropathy. Sometimes they can be weak or have regional anesthesia. They can sometimes lose fingers or toes, not because of the pathology of the disease, but because they've lost sensation, and therefore they damage those limbs and they don't feel it. These patients have a Th2 response, which is not the type of response you want to a leprosy infection. This is humoral immunity with antibodies. They have a depressed cell-mediated immune response, and the antibodies can't reach these bacteria because they are intracellular. We don't really understand why some people have this type of response rather than the better or more stronger Th1 response. But if you do get this Th2 response, you are going to get the much more severe disease like the man in this picture. If you biopsy the skin lesions, you'll see multiple bacteria and you won't see granulomas because you're not getting that cell-mediated response which creates the granulomas in the first place. To diagnose leprosy, you want to do a skin biopsy of one of the lesions and you will see acid-fast organisms. Remember, it cannot be cultured, so never choose culture as the means of diagnosis. And one side note here is that leprosy is one of the many causes of a false positive VRDL, which is a screening test for syphilis. So if you see this in a board question, don't think that this patient has some type of weird syphilis syndrome. Know that they just have a false positive screening test. The treatment is different depending on whether you have tuberculoid or lepromatous leprosy. For tuberculoid leprosy, the treatment is dapsone and rifampin for about 6 months. If you have lepromatous leprosy, the treatment is dapsone, rifampin, and a drug called clofazimine, and you often have to take this for many, many years. It's very difficult to resolve this infection. So let's talk about these drugs in a little bit more detail. Rifampin is a tuberculosis drug, and I talk about this in more detail in the pulmonary module on tuberculosis, but it blocks RNA synthesis. And then dapsone is a very unusual antibiotic. It works by competing with bacterial para-aminobenzoic acid, or PABA, and therefore it inhibits the enzyme dihydroterorate synthase. And this is going to disrupt the folic acid pathways. It works exactly the same way that sulfonamides do. It's only used in 2 situations that you need to know about for step 1. The first is this one, to treat Mycobacterium leprae, as we've been talking about. And the second is to treat pneumocystis jirovecii, which causes pneumocystis pneumonia in patients with HIV/AIDS. And the drug of choice in that situation is sulfonamide, so you can just remember dapsone works the same way, and therefore it's a backup drug to sulfonamides for pneumocystis. Another thing to know about dapsone is that it can trigger hemolysis in G6PD deficient patients, and that is also very similar to sulfonamide. So you can see there's a lot of things you can easily remember about dapsone just by remembering that it works like sulfonamides. And then finally, a unique problem with dapsone, which is very rare, is that it can cause agranulocytosis, and this is where the absolute neutrophil count drops to 0 and people are vulnerable to infections. Very uncommon. And then finally there's clofazimine, and really the only thing you need to know about this is that it's used to treat Mycobacterium leprae infections. It works by disrupting the mycobacterial's DNA, but the mechanism is really not something that's very high yield for you to know about. The last thing I'll mention is a very rare condition called an IL-12 receptor deficiency. Recall that IL-12 triggers the differentiation of T cells into Th1 cells, and activated Th1 cells produce interferon gamma. And these two things are important for the response to intracellular infections, especially the response to some mycobacterial infections. Very rarely children are born with deficient receptors, and these children have a weak Th1 response and they have low levels of interferon gamma. And in these children, it's been shown that they have increased susceptibility to some non-tuberculosis mycobacterial infection. They also tend to get more disseminated salmonella infections. And if you give them the BCG vaccine, which is a live strain of Mycobacterium bovis, it's given to prevent tuberculosis infections. These children can get sick after receiving the vaccine. Interestingly, you can treat these children by giving them interferon gamma, which is the molecule that they are deficient in because they don't have the IL-12 receptors. So this is a very rare condition that it's almost impossible you'll ever see clinically, but you definitely should know about it for your boards because they like to test you to see if you know the purpose of IL-12 and what happens when the receptor doesn't work. And that concludes our module on Mycobacteria.